specific, almost traumatic moment that I think every single person listening has experienced. It's just universal.
Oh, I know exactly what
You wake up, maybe you have a big presentation that day or a first date, or you just want to feel good for once. You walk into the bathroom, you flick on those harsh, unforgiving overhead lights, and you look in the mirror.
And there it is.
There it is.
The beacon.
The beacon. A red, angry, throbbing mountain right in the middle of your forehead. Or maybe it's a painful cluster on your chin that feels like it has its own heartbeat. And the immediate reaction is almost always the same. We trivialize it.
We do. We instantly go into like bargaining mode.
Exactly.
Yeah.
We tell ourselves, ugh, I must have eaten too much greasy pizza last night, or I didn't scrub my face hard enough.
Right, or it's just a spot, I'll just pop it.
Yes, I'll pop it, cover it with concealer, pretend it doesn't exist. We treat it like a hygiene failure or just a temporary glitch in the system.
Which is completely understandable because that is exactly how our culture has trained us to see it. It's viewed as a cosmetic nuisance, something for teenagers, something superficial.
But
But if you actually open the medical literature, and specifically the clinical text we are diving into today, chapter 15 on acne clear, that entire trivial view just completely evaporates.
it really did. I was honestly surprised by the gravity of the language in the source material. We aren't just talking about a bad skin day.
No, we're not. The text defines acne not as a cosmetic annoyance, but as a chronic inflammatory disease.
Disease, that's the key word.
It's a medical condition in the truest sense, involving a very specific, really complex biological cascade. It's a collision of hormones, microbiology, and immunology, all taking place right on your face.
And that is our mission for this deep dive. We are going to move way past the pop it and forget it mentality.
Right.
We are going to look at the microscopic machinery of the skin to understand why this happens. We're going to break down the 4 stages of a pimple's life cycle, which is honestly like a slow-motion car crash happening in your pores.
That's a great way to put it.
And then we're going to analyze the treatments, from the drugstore aisle all the way to the prescription pad.
It is a fascinating journey. You go from the microscopic level to the systemic level. And I think the biggest takeaway for you listening today is going to be this shift in philosophy, moving from treating a spot to managing a chronic environment.
So let's get right into the biology then. The source material outlines pathophysiology, which is just medical speak for how the body's normal functions go wrong.
Yeah, how it all breaks down.
And it turns out a pimple isn't an event, it's a process. By the time you see it, it's already old news.
Precisely. By the time you see that red bump, that process has been underway for days, maybe even weeks. The text breaks this down into 4 really distinct stages.
Okay, 4 stages.
And this isn't just, academic trivia for a test.
Right, this is actually practical.
It's incredibly practical because if you can get your head around these 4 stages, you basically understand every single acne treatment out there.
Oh, wow.
Yeah, every single one. Because every drug, every cream, every pill, it's just a wrench thrown into one of these specific gears in the machine.
So it's like a roadmap to the pharmacy aisle.
Exactly, a biological roadmap.
Okay, let's unpack stage 1 then. This is the invisible stage, right? Nothing in the mirror yet.
Correct. Nothing you can see. Stage 1 is officially called increased follicular keratinization.
That is a mouthful. Let's break that down. What is keratinization?
So your skin is constantly renewing itself, right? The cells inside your hair follicle, the pore, are born, they live, they die, and then they shed. Normally they shed comfortably, effectively peeling off and flowing out of the pore onto the surface of the skin, carried by your natural oils. It's a smooth exit.
Like a well-organized exit from a stadium after a concert.
Yeah.
Everyone files out in an orderly fashion.
Perfect analogy. But in stage 1 of acne, that process goes completely haywire. The text describes a condition called retention hyperkeratosis.
Retention hyperkeratosis.
Yes. Basically, the epidermal cells become sticky, they don't shed properly, they adhere to each other and form this dense, cohesive plug made of keratin, which is a structural protein in your skin, and dead cells.
A plug, so it's a traffic jam.
A total gridlock. And the text calls this the microcomedone.
The microcomedone.
Yes. And you have to remember this term because this is the villain's origin story. It is the invisible precursor to all acne. Every massive cyst or tiny whitehead you've ever had started as a microcomedone you couldn't see. Instead of shedding, those cells created that jam.
So we have a blockage. The stadium exit is locked, but people are still trying to leave.
Yeah.
That sounds like a problem, but it's a silent problem so far.
Right. It's happening under the surface.
Yeah.
But that leads us directly, and I mean directly, to stage 2, increased sebum production.
Okay, sebum is the fancy word for oil.
Right.
And the source material points a finger squarely at hormones here.
It does, specifically androgens. The text notes that acne usually begins in the prepubertal period because this is when androgen production really ramps up. Androgens are the hormones that hand out the orders to the sebaceous glands.
The oil glands.
The oil glands attached to your pores, exactly. They tell these glands to get physically bigger and to just increase their output.
So the factory gets expanded and the assembly line speeds up.
Exactly. A great way to think of it. Now, combine stage 1 and stage 2. You have a factory churning out massive amounts of oil. But the exit door is welded shut by that keratin plug from stage 1.
That is a hydraulic nightmare.
It is. The sebum has absolutely nowhere to go. It gets trapped behind the plug and starts to pool. It starts to solidify and mix with the dead cells. You are effectively building a pressure cooker inside your skin.
And a pressure cooker full of warm oil seems like a terrible place to be, unless you are a very specific type of bacteria.
And that's our cue.
Which brings us to stage 3, bacterial lipolysis.
Enter the antagonist. Propionobacterium acnes, or as it's more commonly called now, Cutibacterium acnes. We'll call it P. acnes to stick with the text.
Okay, P. acnes.
Now, almost everyone has this bacteria on their skin. It's part of our normal microbiome. It's usually harmless. But the source material highlights a critical weakness, or strength, depending on your perspective of this bacteria. It is anaerobic.
Anaerobic meaning it hates oxygen.
Correct. It thrives in oxygen-free environments. So normally on the surface of your skin, P. acnes is kept in check because it's exposed to air.
Right.
But think about what we just created in stage 2. A plugged pore, filled with oil, completely sealed off from the surface.
It's an oxygen-free bunker.
It is a luxury bunker. It's warm, it's wet, it has no oxygen, and it is full of food.
The food being the oil.
Yes. And this is where the chemistry gets really interesting and where the text gives us the term lipolysis. These bacteria don't just swim in the oil, they digest it.
They eat it.
They eat it. P. acnes produces an enzyme called lipase. This enzyme breaks down the triglycerides in your sebum into free fatty acids.
Free fatty acids sounds like something you'd read on a nutrition label, but in the context of a pore, I'm guessing they aren't good.
They are incredibly destructive in this context. These acids are chemical irritants. They essentially cause a chemical burn inside the follicle.
Wow.
This irritation attacks the follicular wall, and crucially, it signals the body to speed up that sticky cell process from stage 1.
Oh no, so it's a feedback loop.
It's a horrible feedback loop.
The bacteria eat the oil, they produce acid. The acid irritates the skin, which makes the plug even worse.
Which seals the bunker tighter.
Which lets the bacteria grow even more.
Exactly. It's a vicious, self-sustaining cycle. And eventually, the body just cannot ignore it anymore. The chemical signals coming from that bunker are getting way too loud.
Which brings us to the explosive finale. Stage 4, inflammation.
This is when the biological burglar alarm goes off. The presence of these bacteria and the damage from those fatty acids, it triggers a T-cell response. Your immune system realizes the perimeter has been breached.
So it calls in the troops.
It effectively calls in the cavalry. It recruits neutrophils, which are a type of white blood cell, to the site.
And when we look in the mirror and see something white or yellow, that's the cavalry.
That is the casualty list of the war. Pus is essentially a collection of dead white blood cells, dead bacteria, and tissue debris. But here is where the damage gets real. The bacteria produce enzymes that increase the permeability of the follicular wall, the pressure from the oil, the rapidly multiplying bacteria, and the influx of immune cells. It all just becomes too great.
And the pipe bursts.
The pipe bursts, the wall of the follicle ruptures, and this is the critical moment. When that follicle ruptures, it dumps lipids, keratin, live bacteria, and those irritating fatty acids directly into the dermis.
The dermis, that's the deeper layer of living tissue.
The living tissue, exact.
Ouch. So that's why it hurts so much. It's not just on the surface, it's an internal wound.
It's a perfect way to describe it. Ideally, your skin keeps the outside world out. Here, the outside world bacteria and waste has been injected deep inside, and that triggers a massive inflammatory response. Redness, swelling, heat, pain, that is an inflammatory lesion.
It really changes how you look at a pimple. It's not just dirt in a pore. It's a ruptured organ, essentially, on a microscopic scale.
That is a perfect way to frame it. And that distinction between the plug and the rupture leads us nicely into the next section of our analysis, decoding the lesions.
Right.
Because people use terms like blackhead, whitehead, and cyst pretty loosely, but medically they represent very different stages of this disaster.
Okay, so the text categorizes them into two main buckets, non-inflammatory and inflammatory. Let's start with the non-inflammatory ones. These are the comedones.
Right. So if the pipe hasn't burst yet, it's non-inflammatory. We have the closed comedone and the open comedone.
The closed comedone is the classic whitehead.
Yes. It's that small flesh color or white bump. The plug is still intact and covered by a microscopic layer of skin. It's precarious because the pressure is building, but it hasn't blown yet. It's a ticking time bomb.
And then there's the open comedone, the blackhead. Now, I have to stop here because this is probably the biggest myth in skincare, the black part. Is it dirt?
It is absolutely not dirt. I cannot stress this enough.
So it's not because I'm dirty.
No. If you take one thing away from this deep dive, please let it be that blackheads are not caused by poor hygiene.
So why is it black? What's going on?
It's just chemistry. The text explains that an open comedone forms when the plug extends up to the surface and dilates or widens the opening of the pore.
Okay.
Because it's open, that plug of oil and dead cells is exposed to air. When melanin, which is your skin pigment, and lipids are exposed to oxygen, they oxidize.
Like an apple turning brown when you cut it.
Exactly like an apple turning brown.
So it's essentially a rusty plug of oil.
That's a great image.
Yes.
It's oxidized debris. It has nothing to do with cleanliness.
Which explains why scrubbing a blackhead to clean it never works. You can't scrub away oxidation.
Exactly. You're just scrubbing the top of a very deep plug. And in fact, as we'll get to, scrubbing can make it much, much worse.
Okay, moving to the scary stuff. Inflammatory acne. We've moved past the comedone. The pipe has burst. We're talking pustules, nodules, and cysts.
This is where stage 4 has completely taken over. Pustules are those visible, pus-filled bumps. Those are superficial ruptures. But nodules and cysts, those are the heavy hitters.
What is the real difference between a regular pimple and a cyst? Is it just size?
It's mostly depth. A nodule or cyst represents a rupture deep, deep in the dermis. It involves a much larger volume of tissue. Because it's so deep, the surface might not even look that bad initially. You don't see a head, but you can feel it.
That hard, painful lump under the skin that feels like a marble.
Exactly that. And the text offers a very sobering warning about these deep lesions regarding healing time.
What does it say?
Well, while a surface pimple might resolve in a week, deep nodules and cysts can take months to heal. Months. The body has to clean up a massive mess deep underground.
And this leads to the dreaded S word, scarring.
Fibrosis, that's the medical term. When the body tries to repair that deep damage, it often lays down excess fibrous connective tissue collagen, but in a disorganized way. That's what a scar is. The source material uses this to underscore a vital point, the need for early treatment.
Right.
You aren't just treating the spot you have today. You're treating to prevent the permanent structural damage that might last the rest of your life.
That's a heavy realization. It shifts the goalpost from looking good for the party on Friday to preserving the integrity of my skin for the next 40 years.
Exactly. And that brings us to the philosophy of treatment. There's a segment in the source referencing the Global Alliance to Improve Outcomes in Acne, and they issued a consensus statement that really, it shifts the entire paradigm.
And their core message is what? That acne should be approached as a chronic disease.
Right. This is the biggest mental shift we need to make. We tend to treat acne like an acute infection like strep throat.
Yeah, you get it, you take a pill, it goes away, you're done.
Exactly. But the text says acne is more like hypertension or diabetes.
Meaning it requires management, not just a cure.
Precisely. If you have high blood pressure, you don't take a pill for a week and then stop when your numbers look good. You manage it long term to keep the numbers down. Acne is the same. That biological tendency to form those sticky plugs and overproduce oil is chronic. So the treatment must be continuous. Maintenance is key to preventing relapse.
That makes so much sense. It's about keeping the biological environment stable. So before we get to the drugs, let's talk about the basics. The text mentions diet and stress. What's the verdict there?
It does, but it's cautious. It advises maintaining a balanced diet and controlling stress, noting that these can be aggravating factors. High glycemic diets, lots of sugar can spike insulin, which can trigger androgens, which triggers oil.
Okay, a domino effect.
Right. And stress releases cortisol, which also messes with oil production. But the text implies you can't cure acne just by eating kale and doing yoga. It helps, but it's rarely the whole solution.
Fair enough. But the hygiene advice in the text is very specific and actually contradicts what a lot of people naturally do.
Let me guess, you're thinking about the scrubbing paradox.
Yes, when you feel greasy and dirty, the instinct is to scrub. Take a rough washcloth or a gritty scrub and just go to town. You want to sandblast the problem away.
And the text effectively says, put the scrub down. It explicitly states that scrubbing should be minimized.
Why? It feels like it should work. It feels clean.
Remember our burst pipe analogy? If you have a fragile pipe full of inflammatory gunk and you take a belt sander to the wall, what happens?
You rupture the pipe.
You rupture the follicle. Aggressive scrubbing can physically break the follicular wall, taking a non-inflammatory blackhead and turning it into an inflammatory cyst. It worsens the inflammation. You are essentially taking a contained fire and spreading the embers all over the place.
That is so counterintuitive, but it makes perfect mechanical sense.
So the recommendation is wash no more than twice daily with a mild non-fragrance soap. Be gentle. You are cleaning a wound, not scrubbing a floor.
And what about extraction? Popping. Everyone wants to know.
The text is polite but firm on this. It notes that while come-down extraction offers immediate cosmetic improvement, it feels satisfying to get the gunk out.
Oh, it's very satisfying.
It is, but it hasn't been widely tested in clinical trials. And in the hands of a non-professional, squeezing usually pushes the infection deeper rather than out. It's a proceed at your own risk. Or, better yet, leave it to a professional esthetician or dermatologist.
Okay, let's open the medicine cabinet. We're moving into the pharmacologic arsenal. The text breaks this down by what the drug is actually doing to those 4 stages we talked about.
Right, and since everything starts with a microcomedone, that hidden traffic jam, let's start with the drugs that target that. We're talking about topical retinoids.
These seem to be the VIPs of the acne world. The text calls them first-line therapy.
They are the absolute cornerstone. If you aren't using a retinoid, you aren't really treating the root cause of the clogs. Retinoids are vitamin A derivatives, and they work by normalizing that follicular keratinization.
So they unstick the sticky cells.
Basically, yes. They speed up the turnover of skin cells and change the way they shed so they flow out individually instead of clumping together. By doing this, they inhibit the formation of the microcomedone.
So they stop the traffic jam before it even starts.
Exactly. And because they stop the process at stage 1, they are crucial for maintenance. They prevent the next breakout, not just treat the current one.
The text mentions a few specific types: tretinoin, adipoline, tazarotene. Are these all basically the same thing?
Similar family, different personalities. Tretinoin is the classic, the grandfather of retinoids. It's incredibly effective, but the text notes it is chemically unstable. Sunlight breaks it down, and it can be very irritating. Also, importantly, it should not be used in pregnancy.
Then there's adicline. I know this one is different. It used to be prescription only, right?
Yes, and now it's over-the-counter in many places, which is a huge deal for access. The text highlights adipoline as a first choice for both treatment and maintenance. The reason is tolerability. It is chemically designed to be less irritating than tretinoin, but just as effective at unclogging pores.
So it's a bit gentler.
A bit gentler, and it's stable in sunlight, too. It's often the best place to start for a beginner.
Then tazarotene.
That's the heavyweight topical. Very effective, but potentially more irritating. Usually applied less frequently or for short contact periods, kind of like a special forces unit.
Now, there is a notorious downside to retinoids. People call it the purge. Does the text explain why your face seems to explode when you first start using them?
It's implied in the mechanism. Since retinoids speed up cell turnover, they bring all those hidden microcomedones to the surface at once.
Oh, so they were already there.
They were already there, lurking. It's not that the product is breaking you out. It's fast-forwarding the pimples that were already brewing deep down. It pushes the debris up and out.
That requires a lot of faith from the patient. You have to endure the storm to get to the calm.
It does. The text advises applying them at night. And here's a pro tip from the clinical guidelines. Apply it 30 minutes after cleansing.
30 minutes. Why wait?
You want the skin to be bone dry. If the skin is damp, it absorbs the medication faster and deeper, which causes more irritation. Drying the skin acts as a buffer, and critically, start slow.
Yep.
Every other night at first. You have to train your skin to tolerate it to avoid the retinoid ugries, that awful peeling and redness.
Okay, so retinoids handle stage 1, the clog. What about stage 3, the bacteria? This is where benzoyl peroxide comes in.
Benzoyl peroxide is a fascinating compound because it is a dual threat weapon. First and foremost, it is bactericidal. It kills P. acnes on contact.
How does it do that?
By releasing oxygen. Remember, P. acnes is anaerobic.
It hates oxygen.
Oxygen is its kryptonite. Benzoyl peroxide essentially drops an oxygen bomb into the bunker. The bacteria cannot survive it. And the amazing thing is, unlike with antibiotics, the bacteria cannot develop resistance to oxygen. It works every time.
Okay, that's impressive. And the second threat.
It suppresses sebum production slightly and helps clear the pores. So it hits stage 2 and stage 3. It is described as the standard of care for mild to moderate acne. And unlike retinoids, which take weeks to show results, benzoyl peroxide acts fast. Within 5 days, you can see a reduction in bacteria.
But there's a catch. My towels know this catch very, very well.
It bleaches everything. Hair, clothing, pillowcases. It
Yeah.
is a powerful oxidizer. If you wipe your face and then touch your expensive navy blue shirt, you'll have an orange fingerprint forever.
And it's drying.
Very. The text suggests starting with lower concentrations, like 2.5% or 4%. And here's a fun fact. Clinical studies show that 2.5% is just as effective as 10% at killing bacteria, but with way less irritation. More burn doesn't mean more cure.
That is really good to know.
Yeah.
What about exfoliating acids? I see salicylic acid in every face wash at the drugstore.
Salicylic acid is a keratolytic,
Yeah.
which is the fancy way of saying it dissolves keratin. It works on the surface to unglue those dead cells. It's great for people who maybe can't tolerate retinoids, or for very mild cases. It's lipophilic, meaning it likes oil so it can dive into the oily pore and clean it out.
So it's a good option.
It's a good option, but generally for chronic inflammatory acne, the text considers it less potent than retinoids or benzoyl peroxide. It's a good supporting character, but maybe not the lead actor.
There was also a brief mention of sulfur and resorcinol. These sound very old school.
They are. Very old school. Sulfur works, it's antibacterial and keratolytic, but the text bluntly notes its offensive odor.
It smells like rotten eggs.
It does. It's hard to feel fresh when you smell like sulfur. And resorcinol can cause a reversible dark scaling on dark skin, so it's largely fallen out of favor compared to the newer, cleaner options.
Now let's move to systemic treatments. This is for when the creams and gels aren't enough. We're talking about pills. And the first category is antibiotics.
This is a really critical section of the text because it comes with a major warning label attached to it.
Yeah, the resistance problem.
Exactly. Antibiotic resistance is a global health crisis. We are running out of effective antibiotics because bacteria are evolving to survive them. And dermatology has historically been a big contributor to this problem because people would take low-dose antibiotics for acne for years.
Years? That seems excessive.
It is. And the text heavily emphasizes, we cannot do that anymore. The strategy is clear. Do not use oral antibiotics as monotherapy, meaning don't take them alone.
You have to pair them with something else.
You must. You combine them with benzoyl peroxide or retinoids. Why? Because the benzoyl peroxide kills the bacteria via oxidation, catching the ones that might be resistant to the antibiotic. It protects the antibiotic's usefulness. And the text suggests limiting their use to short durations, 6 to 8 weeks where possible.
So it's a bridge, not a long-term solution.
Exactly. You use the antibiotic to put out the massive fire, which is the inflammation, while the retinoid works in the background to fix the plumbing, the prevention. Once the fire is out, you stop the antibiotic and maintain with the retinoid.
What are the common ones used?
Tetracyclines are the workhorses here, specifically doxycycline and minocycline. They have both antibacterial and anti-inflammatory effects. They actually calm the immune response down.
But minocycline has some scary side effects listed in the text.
It does. It's generally well tolerated, but the rare side effects are serious. Pigment deposition, it can turn the skin, nails, or even gums a blue-gray color.
Blue-gray gums.
Yes, and it's permanent in some cases. Also, autoimmune hepatitis and a lupus-like syndrome. It's why doctors monitor patients on these drugs so carefully. It's not just a benign pill you pop like candy. It has systemic implications.
Okay, so for women, there's another systemic route.
Hormones. Since we know androgens drive sebum production, that's stage 2, blocking them just makes sense. Oral contraceptives that contain estrogen can be very effective because they increase a protein that binds up the free testosterone in the blood, making less of it available to stimulate the oil glands.
And what about spironolactone?
The text mentions this as an anti-androgen. At higher doses, it blocks the androgen receptor on the oil gland itself. It essentially puts air plugs on the oil gland so it can't hear the hormonal command to make more oil. It's highly effective for hormonal acne in adult women, particularly that stubborn jawline acne.
Okay, we have reached the final frontier, the segment I've been waiting for. The nuclear option. Isotretinoin, formerly known by the brand name Accutane.
This is the heavyweight champion. The text states clearly, it is the only drug that produces prolonged remission. For many patients, this is the closest thing to a cure that exists.
How does it work? Does it target one of the stages?
It targets all of them.
All four.
All 4. It is the only drug that hits all four factors. It decreases sebum production dramatically by up to 90%. It physically shrinks the oil glands. Because there is no oil, P. acne starves and dies. It reduces inflammation. It normalizes keratinization so the pores don't clog. It effectively shuts down the entire acne factory.
That sounds like a miracle drug.
Yeah.
If it does all that, why isn't everyone on it?
Because the nuclear option implies fallout, and the fallout can be significant. The text calls these the cost of cure. The side effects are frequent, predictable, and dose-related.
Let's list them. What happens to the body?
Well, it shuts down oil production everywhere, not just in the pimple. So mucocutaneous effects happen in 90% of patients. Cheilitis, which is severely dry, cracking lips, is almost guaranteed. If your lips aren't chapped, the drug probably isn't working.
Wow.
Dry eyes, dry nose, leading to nosebleeds, skin peeling. You essentially dry out from the inside out.
And systemic risks.
Yeah.
What about inside the body?
Lipid spikes. It can cause high cholesterol and triglycerides, so you need monthly blood tests. It can cause hyperglycemia. And there is a potential link to depression and mood changes. The text notes this is controversial. Studies go back and forth on causality, but clinically, patients must be screened for it.
But the biggest warning, the one in bold print, metaphorically speaking, is teratogenicity.
Yes. Isotretinoin is highly teratogenic. This means it causes severe life-altering birth defects if taken during pregnancy. Brain defects, heart defects, facial deformities. This is absolutely non-negotiable.
And this is why the IPLJG program exists in the U.S.
Correct. It is a mandatory, strict distribution program. You can't just pick this up at the drive-through pharmacy. Female patients of childbearing potential must use 2 forms of contraception, starting 1 month before therapy and continuing for 4 months after. They have to take monthly pregnancy tests in a lab. The doctor has to log the results. The pharmacist has to check the system before dispensing.
That's a huge ordeal.
It's a massive bureaucratic hurdle, but it shows just how seriously the medical community takes this risk.
It's a high-stakes treatment. But for severe nodular acne that causes scarring, it changes lives.
It does. It saves skin, preventing that permanent fibrosis we talked about. And frankly, it often saves the patient's self-esteem. It can give someone their life back.
Which brings us to our outro. We've covered a lot of biology and chemistry, but I want to talk about the timeline. We live in an instant gratification world. If I start these treatments today, when do I see clear skin?
The text preaches patience, which is the hardest prescription to swallow. This is a waiting game. The evaluation of therapeutic outcomes takes time. The text notes that lesion counts might decrease by only 10 to 15% in the first 4 to 8 weeks.
That is barely noticeable. That has to be so demoralizing for people.
It is. And if you are purging on a retinoid, it might even look worse for a bit. But you have to trust the biology. A 50% reduction usually takes 2 to 4 months, and total clearance can take longer.
So the takeaway is, stick with it.
Stick with it. Consistency is more important than intensity. Don't jump from product to product every week because you aren't seeing a miracle. You are trying to turn around a cruise ship, not a jet ski. You have to give the biology time to reset.
We've moved from the microscopic keratin plug to the immune system's explosion. From salicylic acid washes to the sheer intensity of isotretinoin. It's a complex landscape.
It is. And if we connect this to the bigger picture, think about that final provocative thought from the source material.
Yeah, this really stuck with me. The text explicitly links acne treatment to psychological scarring and depression. It acknowledges that this skin condition has profound mental impacts.
Exactly. And yet, culturally, we often dismiss it. We tell people it's just a phase or it's just cosmetic. But if acne is a chronic disease with complex biological drivers and serious mental health consequences, why do we treat it as a trivial issue?
Why do we wait until scarring has already occurred to take it seriously?
Right. The biology suggests we should treat it like any other chronic disease, early, effectively, and without judgment.
That is the ultimate conclusion. Understanding the biology allows us to have compassion for our skin and for the skin of others. It's not dirt, it's a disease, and it's treatable.
It is.
So next time you see that spot in the mirror, remember the war going on in that follicle. Be patient with your skin. It's doing its best. Thanks for diving deep with us today.
Until next time.